We are live, sir.
Shall we start?
Yes, sir, you can start. Hello, Dr. Dinesh, you can start.
Yeah. Good evening, everyone. I am Dr. Dinesh Kumar on behalf of Lucknow Diabetes Study Society. Welcome you all this evening. Today, we are going to discuss a very important topic, sexual dysfunction in relation to diabetes. This complication of diabetes is a hidden complication. Usually we discuss about the microvascular complications like nephropathy, retinopathy, and neuropathy, and macrovascular complications like cardiovascular mortalities, CV deaths, and diabetic foot syndrome. But rarely or very infrequently do we discuss about sexual dysfunction among ourselves in any CMEs or even with the patients. Today, in fact, we did a study on this sexual dysfunction in relation to diabetes, and our study was presented this year, ADA 2020, as an oral poster presentation or virtual poster presentation. And on this platform, again, we are going to discuss or present our study in front of you all, and that will be the topic of discussion for today. Before beginning the program, I would like to request Dr. Muklesh Gupta, Secretary, Lucknow Diabetes Study Society, to say a few words about our origin and the progress.
Thank you so much, Dr. Dinesh, and I formally welcome each and everyone on board here today. And just to mention briefly about Lucknow Diabetes Study Society. Our society LDSS that formally came into being on 7th of August 2018 with prominent objective of quality research in the field of diabetes and allied sciences. It was a group of like-minded centers in the geopolitical regions of Lucknow, and this group basically comprised of endocrinologists, diabetologists, cardiologists, and physicians. In a very short span of time, we have made our presentations in EASD 2019 and also this year in ADA 2020, about which we will be discussing a bit today. Couple of our research publications are already in pipeline and yet to be published. We are a group of private practitioners basically, and we understand that data coming from Uttar Pradesh or region hereby basically is very scarce. And private practitioners basically, they fall back if we talk of the data generation. With that mind, we probably came together and we luckily are having group of good people around and a lot of large data which we are capable of coming in. In fact, our hypoglycemia study that encompassed nearly 1,200 patients. And the current study which we are presenting is somewhere around 460 patients. So good amount of patient load, and therefore we probably are in a position to give good quality research as far as the diabetes and allied sciences is concerned. Here I would like to specifically mention about our president, Dr. Rajiv Awasthi, whose able guidance, support, and help keeps our morale very high and full of energy always. So without spending any further time, I would now request Dr. Dinesh to introduce our esteemed chairpersons who have blessed our organizations with their presence. And it's really privilege of having such elite group of chairpersons, those who will be guiding through this presentation process through this 1 hour and a few minutes. So over to Dr. Dinesh to introduce our esteemed chairpersons.
Thank you, Dr. Muklesh. The topic we are going to discuss is assessment of sexual dysfunction in men with type 2 diabetes. And for that, we have chairpersons. First, the international chairperson, Professor Silver Bandeke, FRCPI PhD, Honorary Senior Consultant Physician, Diabetes and Endocrinology, St. Francis Hospital, Zambia, Kampala, Associate Professor, Diabetes and Endocrinology at the Mother Kevin Postgraduate Medical School, Uganda Martyrs University, Kampala, Uganda. His accreditations are Chair, he has been a Chair East Africa Diabetes Research Group. He is the past Chair of International Diabetes Federation, Africa region from 2009 to 2013. His research interest has been in beta cell function and pathogenesis of type 1 diabetes in the African population. He has many publications to his credit. And we have Professor Dr. Sushil Gupta, Department of he's a professor in Department of Endocrinology, SGP JIMS Lucknow. He has more than 25 years of teaching experience to the DM and PhD students. He's an associate editor, World Journal of Endocrine Surgery. He's a secretary, Indian Society of Bone and Mineral Research, UP chapter, Lucknow. He's an executive member of Endocrine Society of India, executive member Task Force DBT, member Program Advisory Committee, Regional Center for Biotechnology, Faridabad. He's an examiner in the DM programs, member of Faculty Selection Board, AIMS, Jodhpur. His research interest is in bone and mineral research, osteoporosis, and he has reviewed many research publications and he has been co-author in many books and chapters. Next, we have Dr. Sanjay Kalra, MD DM AIMS Delhi, consultant and head, Bharti Research Institute of Diabetes and Endocrinology, Karnal, Haryana. He is a present president of the Endocrine Society of India. He is a vice president, South Asian Federation of Endocrine Society, education editor in the Indian Society of Endocrinology. He's a section editor of the endocrinology part in the API textbook of medicine, associate editor, Diabetic Medicine UK, section editor, Diabetes of the ESI Manual Clinical Endocrinology first and second editions. He has won many awards, and one of them has been Global Dawn Award for the Best Translational Research in Diabetes in 2009, and he has in many publications in the international and national journals. So we have two topics, which will be, first we'll be presenting our study that has been presented in ADA 2020. And for that, we have the first speaker, Dr. Vivek Agarwal. I will be introducing the speakers on behalf of the chairpersons. Dr. Vivek Agarwal will be presenting about assessment of sexual dysfunction in men with type 2 diabetes, the introduction and the methodology part.
Thank you, Chairpersons. Thank you, Dr. Dinesh. With your permission, can I share my slides?
Yeah, please go ahead.
So it's my privilege to present the study that we as a group of Lucknow Diabetes Studies Society conducted. This was regarding assessment of sexual dysfunction in men with type 2 diabetes. This erectile dysfunction is a common problem among men, which is hardly discussed by the patient themselves, and sometimes there is inertia from the physician's mind also. It is a big problem. Magnitude of problem is large. Almost 150 million men all over the world are having some erectile dysfunction. Diabetic patients have threefold higher risk as compared to the non-diabetic population. Almost 35 to 90% male with diabetes have erectile dysfunction. The lifetime prevalence is approximately 75%. Almost all or 95% of diabetic male have some erectile dysfunction after age of 70 years. And it is of concern that diabetes patients in India have erectile dysfunction almost a decade earlier uh, than their control counterparts. And it is rather more severe and less responsive to treatment as compared to other erectile dysfunction patients. Erectile dysfunction is defined as disorder characterized by inability to attain or maintain an erection sufficient to allow satisfactory intercourse. The risk factors could be long-standing type 2 diabetes, obesity, smoking, sedentary lifestyle, comorbidity like hypertension, depression. There could be some therapeutic drugs that we use for such patients. Those medicines can increase the risk of erectile dysfunction, or there could be some recreational drug usage in such patients. The pathogenesis is quite complex and multifactorial. Recent studies have suggested that this could be early sign of endothelial dysfunction, and erectile dysfunction as such could be considered a risk factor for cardiovascular disease. The major component in this erectile dysfunction is contributed by diabetic neuropathy. Macrovascular arterial disease also do occur in such patients. There is some structural remodeling of the corporeal tissue. There is some psychogenic component. Diabetic males are having higher risk of developing hypogonadism, and some drugs have adverse drug reaction leading to erectile dysfunction. There are some rheological correlations like increased eosinophil count, platelet counts, the increase in mean platelet volume, the large cell small cell ratio. These are the known correlations, but they do not have a causal relationship with erectile dysfunction, but they are usually found to be altered in erectile dysfunction patients. Diagnosis of erectile dysfunction is usually questionnaire based, although to rule out the organic cause, penile test and the hormone assays are required in many of such patients. Treatment options are limited. One has to stop smoking, alcohol, and one should reduce weight. Exercise and other lifestyle modifications do help in such patients. There is role of psychotherapy. In erectile dysfunction patients, sildenafil, tadalafil, and other PD5 inhibitors are effective and should be used. In resistant cases, vacuum constriction devices and penile implants could also be used. There are various scales for assessment of sexual experience. I have mentioned 5, there are many. One which we have used is International Index of Erectile Dysfunction, or the IIEF scale, or the questionnaire. There is Arizona Sexual Experience Questionnaire, ASEX. This can be used for both men and women. Brief Male Sexual Functioning Inventory, BMFS. Sexual Functional Questionnaire. This can be used for those who are mentally retarded or not psychologically healthy. And Changes in Sexual Functioning Questionnaire, CSFQ. To brief about IIEF, which we have used, this was first published in 1997 by Rosen et al. This addresses relevant domains of male sexual function. This is psychometrically sound, and it has been linguistically validated in 10 languages in the initial phase, and later 32 languages were validated for this questionnaire. This questionnaire is readily self-administered in research and clinical settings. The beauty of this questionnaire is that it is highly sensitive and is specific for erectile dysfunction, and it can also be used to monitor responsiveness to therapy. This is how this questionnaire look like. It is a 15 question questionnaire, and one has to answer about these questions for their experience in the last 4 weeks. 4 weeks time is taken so that the recall bias is not there. Each question has 6 options, 0 to 5. The maximum score is 5 for each question. Here, sexual activity is defined as intercourse, caressing, foreplay, and masturbation. Sexual intercourse is defined as sexual penetration of the partner, sexual stimulation as situations such as foreplay, erotic pictures, etc. Ejaculation is ejection of semen from the penis or feeling of ejection even without actual ejection. Orgasm is fulfillment or climax following sexual stimulation or intercourse. So this questionnaire addresses 5 functional classes, and these functional classes are represented by set of questions. Each question has 5 score as maximum, and there is a value below which one has to be cautious and should be treated depending on the situation. So the first and most important is erectile function. This includes 6 questions, question 1, 2, 3, 4, 5, and 15. The maximum score is 30. Below 14 is a critical score below which one must be treated, and such patients who have decreased uh, score in this erectile function are most benefited with PDE5 inhibitor usage. Orgasmic function is represented by question 9 and 10, and this group of patients require further workup by the specialists. Group C is sexual desire, and if the person has lower sexual desire or the lower score, their hormonal levels should be assessed. Regarding section D and E, it are about satisfaction of the sexual activity, about intercourse satisfaction and the overall satisfaction, and this group of patients are benefited by the counseling, psychometric counseling. Though this was not part of the initial IIF questionnaire, later on severity scaling was tried and given as no ED if the score is 26 to 30, mild as 22 to 25, mild to moderate if it is 17 to 21, moderate 11 to 16, and severe if it is below 10. In our study, we translated the questionnaire to Hindi because Hindi is the regional language that we commonly use in Uttar Pradesh or the North India. Initially, this IIF questionnaire, which is already a validated questionnaire, it was translated to Hindi by editor of a magazine, which was evaluated by 10 physicians. Then this questionnaire was filled by 5 volunteers who understand both Hindi and English. This was R1 revision, and similar was done 4 times by 5 volunteers who understand both the languages. After the 5th revision, this was subjected to 50 volunteers who understand both, and finally a validated questionnaire translation was used in our study. The study objectives were to determine the prevalence and the risk factors of erectile dysfunction among men with type 2 diabetes mellitus. The study was conducted at 11 centers. The study also assessed the association between erectile dysfunction and other confounding factors: age of the patient, age of onset of diabetes, duration of disease, extent of diabetes control, diabetes associated complications, which could be macro or microvascular, and the prescription drugs. This was multicentric observational study. This was based on validated questionnaire, which was either self-administered or assisted by the healthcare staff. This was translated to Hindi and validated, and as per the patient's preference, both Hindi or English questionnaire could be used in a particular patient. The study was conducted between August 2018 to April 2019. 460 sexually active males of age more than 18 years who had diabetes were enrolled. The primary outcome was to assess the prevalence of erectile dysfunction in patients with type 2 diabetes. Secondary outcome was to evaluate various parameters associated with erectile dysfunction. Subjects responded to IAF on their subjective feeling related to erectile dysfunction, orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction in past 4 weeks. This whole data was put in a Excel sheet and further used a software to assess these associations. The results would be narrated and presented by my colleague. Thank you very much.
Stop sharing your screen, Dr. Vivek.
Thank you, Dr. Vivek. I'm sorry for the because there's some technical glitch. I could not formally introduce you. Dr. Vivek Agarwal is our member of Lucknow Diabetes Study Society. He's a consultant physician, Hindustan Aeronautics Limited, Lucknow. He's a consultant physician, RR Diabetes Heart Care Center, Lucknow. He's a fellow of Indian College of Physicians and fellow of UP Diabetes Association. Received Investigator of the Year Award 2018 and 19 by Indian Society of Hypertension. Member of American College of Physicians. He has published 8 articles in prestigious medical journals and contributed to many chapters in various medicine updates and textbooks. Thank you, Dr. Vivek Agarwal.
Thank you.
Next, we have Dr. KP Chandra. He will be talking about the same topic, that is erectile sexual dysfunction in men with type 2 diabetes that we presented the study. And he will be telling about the pathophysiology and the management part, the results and discussion part. Dr. KP Chandra will be telling us about the results and discussion part of our study. Dr. KP Chandra, DFID CMC Fellow EACD Netherlands. He's an MD General Medicine, consultant physician and diabetologist, Health City Trauma Center and Multi-Speciality Hospital, Gomti Nagar. He's the director of Dr. Chandra's Diabetes and Heart Clinic, Gomti Nagar. His accreditations are American College of Physicians, Association of Physicians of India, Indian Academy of Echocardiography, Research Society for Study of Diabetes in India, Indian Society for Clinical Research, UP Diabetes Association, Lucknow Diabetes Study Society. He's a treasurer of Avidas, and he's also treasurer in the Indian Podiatry Association. Over to Dr. KP Chandra.
Thank you very much, Dr. Dinesh and Dr. Muklesh. So am I audible?
Yeah, loud and clear.
That's great. So good evening, respected chairpersons, ladies and gentlemen. So this is a wonderful occasion where I'm just presenting you the results that we did have from the study we conducted in Lucknow. Actually, this study was conducted at 11 different centers in Lucknow, and the patient included represented the overall different socio-economic status and religious. So in the geopolitical position of Lucknow, 11 different centers, let us see what are the baseline characteristics of the study population, and let us see are they representing the true population that we see in our clinics. So the average age of the patients who attended this study was 47 years plus minus 10 years. We did see that most of the patients were non-smokers, that is 80% of them were non-smokers. Similarly, tobacco use was seen in about 1/4 of the patients. Alcohol consumption was also seen in less than 1/4 of the patients who were included in this study. Height 165 centimeter plus minus 8 centimeter, weight 75 kg plus minus 13 kg, waist circumference 97 centimeter plus minus 10 centimeter, BMI 26 plus minus 4, pulse rate was somewhere near 90, systolic blood pressure 131 plus minus 70, diastolic blood pressure 80. The another important parameter which we evaluated was the duration of diabetes that these patients had. And what we did see that most of the patients which were included in this study were having diabetes for more than 1 year and less than 10 years. Most of the patients were of type 2 diabetes. Only one patient of type 1 diabetes was included into the study. Another important data that we got from our study was the age of onset of diabetes. And what we could find out that average age of onset of diabetes in the population studies was around 40 years with a standard deviation of 10 years. We all know diabetes and hypertension go together. In our population, about 42% of the patients had concomitant hypertension. Hypothyroid was seen in 12.61% of the patients. Let me tell you, these are male patients. And in male patients with diabetes, we did see about 13% of the patients having hypothyroid. History of hypoglycemia was taken, and it was seen in about 13% of the patient. Another important parameter, which was HbA1c, and in our study, the mean HbA1c was 8.49. Let me remind you that most of the studies that are being conducted in diabetes from the real life, the mean HbA1c control is somewhere near 8, and that was the latest study. A bigger study was Indian diabetes study under ICMR, and they also did show that average HbA1c level was about 8. Macrovascular complications based on the history given by the patient was seen in about 10% of the patients, and microvascular complications were seen in about 17% of the patient. So the baseline characteristic itself is explaining that we have chosen a patient population which is representing the mixed population consisting of patients across the different socioeconomic strata and different religions, and they have been representing the real patient population which attend our regular private clinics. Now let us see what is the prevalence of erectile dysfunction in our study population. Patients were given IIEF, and that erectile dysfunction was measured based on the erectile dysfunction domain, and those having values less than 14 were considered to have erectile dysfunction, and about 1/3 of the patient had erectile dysfunction as per the IIEF ED domain. Now we evaluated these erectile dysfunction with different parameters that we monitored in our study, and one of the strongest parameter which has good correlation with erectile dysfunction was age. We have seen that patients younger than 30 years didn't have erectile dysfunction. However, from the age group of 31 to 50, erectile dysfunction was seen in around 26 to 27% of the patients. As the patient's age was increasing, erectile dysfunction increased up to the range of 42 and 48 in age group of 51 to 60 and more than 60 respectively. Similarly, age of onset of diabetes, we can see younger age group, lesser frequency, and higher age group, higher frequency. So the both data put together tells us the importance of age, because age is associated with many other concomitant illnesses like hypertension, dyslipidemia, many psychological and hormonal changes which occurs with age. So finding age having a strong correlation with erectile dysfunction is what it is expected, and we did see in our study also. Then duration of diabetes was studied, and you can see that duration of diabetes was significantly associated with incidence of erectile dysfunction. Or other parameters It has already been said that erectile dysfunction is a mixture of endothelial dysfunction, neuropathy, and many other inflammatory factors which lead to it. And there are role of hypertension, dyslipidemia, macro and microvascular complications in causation of the erectile dysfunction. In our study, where about 40% of the patients had hypertension, we did not see any correlation of erectile dysfunction with hypertension. Similarly, past history of hypoglycemia was not seen to be significantly associated. One of the most important parameter was macrovascular complication, which was significantly associated with erectile dysfunction. We all know the importance of microvascular complication, and we all know that erectile dysfunction is considered one of the screening parameter for evaluation of coronary artery disease. In our study, we did not see correlation between microvascular complication and erectile dysfunction. Similarly, HbA1c levels did not show significant correlation with erectile dysfunction. However, serum creatinine level, so to say kidney function, was significantly associated with erectile dysfunction. Use of drugs were also evaluated. Beta blocker was associated with erectile dysfunction. However, statin was not seen to be associated with erectile dysfunction. So what we did see that out of 460 patients, about 32.4% of the patient had erectile dysfunction. Simultaneously, we evaluated orgasmic function defect also, and we did see that in comparison to erectile dysfunction, orgasmic function defect was more common. When both these things were put together, around 48.8% of the patient had some of the sexual dysfunction, either ED or OFD or both. We all know that erectile dysfunction or sexual dysfunction go together, and usually orgasmic dysfunction, which may include early ejaculation, late ejaculation, not able to achieve orgasm or not getting satisfied with the orgasm, are going together. And in 27% of the patients, out of 48%, 27% had both dysfunction. Now, let us understand the physiology of orgasm. A lot have been understood about erectile dysfunction. We have known about the way engorgement occurs in the penis that leads to tumescence. But orgasm has not been understood or studied well till now. Orgasm is a subjective experience in both men and women, and it has been difficult to determine an objective marker of orgasm. Orgasm is one of the most intense pleasure which is attainable to an organism, yet its underlying mechanism remains poorly understood. In healthy men, there is associated ejaculation, and in both genders, there are involuntary muscular contraction of the striated and perineal muscles. So orgasm is somewhere mediated through the peripheral nerves, mediated through autonomic nerves, and we know that in diabetes, when neuropathy is involved, peripheral neuropathy and autonomic neuropathy is very common, very prominent and common. So what we did is try to evaluate the orgasmic function defect in different categories, and we did see that orgasmic function defect was significantly associated with age categories, that is onset of disease and age of the patient. It was also significantly associated with duration of diabetes. It was significantly associated with creatinine. However, the other things which were not seen to be associated significantly with erectile dysfunction were seen to be associated with orgasmic function defect also, and they were hypertension, which was significantly associated with OFD, history of hypoglycemia, significantly associated with orgasmic function defect, macrovascular complication, significantly associated with orgasmic function defect. Microvascular complications, which was not seen to be associated with erectile dysfunction in our study. However, it was seen to be associated with OFD in our study. Mean platelet volume, there have been many literature which has suggested about mean platelet volume, platelet count and eosinophil count, but in our study we did not see any correlation between mean platelet volume with either erectile dysfunction or orgasmic function defect. Association of OFD with statin and beta blockers were found to be significant. One of the important parameter was HbA1c, and we did not see significant correlation of erectile dysfunction with HbA1c. However, significant correlation was seen with orgasmic function defect. Now, this erectile dysfunction is a result of long-term diabetes, is a result of long-term complications, is a result of long-term endothelial dysfunction which has occurred, and HbA1c probably is telling us about the extent of diabetes control in only past 3 months. Most of the patients coming to the private clinic are being managed according to that, and this HbA1c, which is representing only 3 months of blood sugar, was not seen to be reflecting the overall pathophysiology of erectile dysfunction which has occurred over the years in patients of diabetes. However, orgasmic function defect was seen to be associated with HbA1c. So, few results that we did have was a more correlation was seen with orgasmic function defect, but whatever parameters we did see. Since orgasmic function defect has not been well studied, and there is a lot of scope where we could try to find out about these factors which have been found to be associated with orgasmic dysfunction, and a lot of studies can be done to find out the correlation and the way this orgasmic function defect can be improved in patients. A little bit about the literature that we do have about erectile dysfunction, the results that we did have, why does it differ from the results that are seen from other studies? The prevalence of erectile dysfunction has been reported in a wide range from 35% to 90%. A study conducted in northern Sri Lanka had 62.9% of the diabetic patient having erectile dysfunction, with 22.4% having severe erectile dysfunction. Similarly, a global meta-analysis involving more than 88,000 patients have shown 60% incidence of erectile dysfunction. There have been few studies from India also, particularly Agra, Jaipur and Jammu, and in these cases also we have seen that erectile dysfunction was seen in about 60 to 65% of the patients. Why was erectile dysfunction seen less in our patient? Few causes would be that these studies were done single center study, were done in medical colleges, and people reaching on tertiary center might be in their advanced disease status, and so the erectile dysfunction might be more there. However, one of the most important parameter that I want to state is the cutoff point taken in ED domain. As told by my previous speaker, that scores below 26 was considered as mild ED, less than 21 to 16 it was considered as moderate ED, 16 to 11 was considered as, and less than 10 was considered as critical ED. So the studies have taken different cutoff values. In few studies, scores below 21 were considered as erectile dysfunction, whereas in some other studies the cutoff value of 10 was taken as function of erectile dysfunction. So these values are differing. The study which was done in Agra considered 21 as their cutoff value. So we see a wide range depending upon the cutoff value of the domain being taken. And in our domain, we had taken 14 as cutoff, which was basically the cutoff value which was seen in the first publication on IEF 1996, where patients had values near 13.5 or 14. A little bit about orgasmic dysfunction disorder. Patients with type 2 diabetes also have high prevalence of orgasmic function disorder, and orgasmic function disorder was included in our study. Jaka and Ramesh reported that amongst patients who are having sexual dysfunction, 38% of the patient had orgasmic dysfunction also. However, in our study, what we did see that orgasmic dysfunction was more common and correlating more with the different parameters we had evaluated. Malvis in 2008 reported premature ejaculation in 40% of the patients of diabetes, and there was a strong correlation of erectile dysfunction with premature ejaculation. We have seen that the common group in our study was also about 70% of the patient was common.
Dr. KP, you need to conclude now.
Okay, sir. So erectile dysfunction and lifestyle, none of the various lifestyle parameters that we did study had association with erectile dysfunction. Smoking, alcohol, and BMI have been studied in different studies with varying results. Somewhere there have been correlation, somewhere there have not been correlation, and in our study there was no correlation with lifestyle. Erectile dysfunction with micro and macrovascular complication. In our study we did see an association with macrovascular complications. This is well established. A couple of references are there in ischemic heart disease and in patients having previous CAD. Up to the tune of 80 to 90% of the patient had erectile dysfunction, and in our study also erectile dysfunction was associated with macrovascular complications. At the end, I would like to say something about the strength and limitations of our study. The key strengths are large sample size, multi-center study, assessment of association with wide range of variables with erectile dysfunction, and being multi-center study, we have been able to depict a wide spectrum of subjects. However, there are some limitations. We didn't have healthy control group with which we could compare the data and interpret it. There was lack of information regarding the proportion of patients who were receiving treatment for erectile dysfunction. A study did not cover psychological parameters such as depression, which is quite common in diabetic patients also. Data on association of erectile dysfunction with dyslipidemia was not done. Another important limitation was sexual dysfunction in female. We all have known now that sexual dysfunction in female diabetes patients are also common, and future research would be needed for studying sexual dysfunction in women also. Thank you very much for your patient hearing, and back to our team. But before I end, I would like to just let you all know that this is the team of 11 persons. We work together, we have come together, and we are trying to do some genuine research away from our routine clinical work, and we work together and trying to strive and do our best. Thank you very much.
Yeah.
Thank you, Dr. KP Chandra. Regarding our study, I would like to spend a few minutes on the discussion regarding this study, and we have a few questions from the audience, and we like to have expert opinion from our chairpersons regarding our study and a few questions that have been raised by the audience. I would like to have the opinion of our esteemed chairperson, Dr. Silver.
Thank you very much, and good evening to all those who are attending the session. A very good study, and addressing various issues that we see in diabetes. I see one of the comments as someone asking that patients do not divulge the information of sexual dysfunction. And as clinicians, usually you have to ask this question directly. Sometimes it's difficult, particularly when the male is accompanied by the female partner. They feel shy in expressing the difficulties. So it's the duty of the doctor to actually ask the question directly. Do you have any problem with your sexual function? And usually then they will open up. As you'll find that in Lucknow, where the study was done, they addressed several factors, but you'll find that each area has various areas that are important to address. Psychological factors, which was one of the limitations, is indeed one of the difficulties. And we do see patients who have had diabetes one day and they come complaining of sexual dysfunction, mainly because they have heard about it and it's purely psychological and not. So these are the issues that have to be addressed. But indeed, this is a very good study, and it is important to address the issue because it does have an effect on the metabolic control later on. Patients get depressed. Patients have not been able to address the issues about it, and they feel shy in addressing them. I think Kara has been talking about this subject before at our African Diabetes Congress, and I'm sure he's going to add on a little more.
Thank you, sir, and thank you for your comments. Actually,
Thank
it
you,
is
Dr.
very
Silva.
challenging to take a history, to take a good history. And the first step is to make the person in front of you feel comfortable. And you can always explore the subject. While you take a history, move from a non-threatening to a threatening question. So first of all, you can talk about general health, then physical health, psychological health, and then sexual health. When you're talking about sexual health, let's say you want to take a history. Suppose you want to take a history of exposure to sexually transmitted disease. A good idea would be first to talk about premarital exposure. People will feel relatively free. So how naughty were you when you were in hostel? And after that, you talk about current sexual health or exposure to STD. Talk about heterosexual exposure first, homosexual exposure after that. Don't jump to that. If there's a sexual fetish that you want to talk about, don't ask about it immediately. Other ways that we follow in the OPD are first you ask urinary complaints. So any issues? Do you have any burning micturition? Do you have any pain while passing urine? Now these are non-threatening questions. From there you move on to any infection anywhere in the body. Maybe any infection in the area where you pass urine. So when you translate these sentences into Hindi or into Punjabi, they sound very non-threatening. And then after that, okay, do you have any weakness? Now, by this time, the patient feels comfortable with you. If the patient has any kind of a weakness, which might be physical, psychological, sexual, the chances of the patient opening up are more. Also, if you have a patient with unexplained depressive symptoms, unexplained hyperglycemia, then spare some more time to talk about these symptoms. And most often, the patient will come back to you the next week or the week after that, and he'll say, doctor, last time you were asking me about this. At that time, I didn't open up, but I actually do have this problem. So I think that's a nice way of doing it. Another way is to sort of structure sexual dysfunction or structure sexual function into 3 or 4 parts. Number 1 is libido. How hungry are you for sex? Number 2 is erectile function. How strong do you feel? And then the number 3 is ejaculation. Do you spend enough time? Do you feel content at the end of the event? In Lucknow, Dr. Silver, they speak Urdu and they speak a very nice form of Hindi. So the words for orgasm are very nice. Sukoon, tripti, nasha. Depending upon whether you want to speak in more of Hindi or more of Urdu, all these words are there. And these are also relatively less threatening. If I'm talking about enjoyment, that is less threatening than me accusing the patient of being impotent. If I say, are you able to stand up or not? That's a very threatening statement to a young male. He will feel upset. He will feel uncomfortable with me. So these are some ways. And I think through the Lucknow Association for Study of Diabetes, we can also share simple methods. We can share printouts with everybody of how actually to take a sexual history.
Thank you, Dr. Silver, and thank you, Dr. Sanjay, for your expert words of wisdom. Dr. Sushil Gupta, am I audible?
It's a very interesting study, actually. I congratulate I
Thank you.
congratulate the whole team, Dr. Muklesh, Dr. Chandra, and other guys in the whole study. It's a very interesting study, very nice exploratory study actually. And I think there's a first kind of study of the first kind. In I would be wondering if there could be some control population because we did a study of andropause in non-diabetic population, and sexual activity really declines after the age of 50, 55 years actually. So it's really worth looking at the control population and compare your data with that. Otherwise, overall, the study is extremely good, very exploratory, and really gives further insight into the whole issue of sexual dysfunction. Uh, I'm a little surprised that your statistics showing that the HbA1c less than 6 and more than 6 did not make a much of a difference actually. The second issue is, was this questionnaire self-administered or it was administered in the clinic? Because response rate about sexual dysfunction sometimes is better when they do it at home actually, and not in front of the room. A lot of people still hide a lot of their feelings or responses in the questionnaire when they fill it up actually. So I'm just wondering, it is self-administered questionnaire filled out at home or at the clinic?
Questionnaire was given to the patients,
Dr.
and some of
Muklesh, can you respond to this?
This questionnaire
No,
was self.
it was given to the patient as self-administered, or
Yes, it was self-administered. The patient was given this questionnaire and separate privacy of a separate room, wherein he can silently read and fill in the questionnaire. If at all there is a question in understanding a question, then he was suggested that if suppose you are not understanding or maybe a bit confused, you can call the person who is sitting outside. So this was the methodology which was used for filling this questionnaire.
I think another
There is
issue is that, yeah,
Yeah, I like
yeah,
to
please carry on.
get your expertise on the questionnaire. One question which is raised regarding testosterone and the association with erectile dysfunction, which is coming up in a big way. So probably that is something someone is asking. So let me get your words of wisdom on that particular topic and association with erectile dysfunction.
There are few studies of correlation of erectile dysfunction with testosterone, but a lot of studies are on the other side also that it is inbuilt into the person's psyche about erectile dysfunction. The persons who are hypogonadal, they do improve with testosterone replacement therapy, but with normal testosterone, they don't respond to testosterone replacement therapy. So there is some partial correlation with that. Even the subjects who have got hypogonadal, don't have erectile dysfunction to that extent as we assume. Actually, that's an issue here. So
Thank you,
there is
sir.
a no one-to-one correlation of testosterone deficiency with erectile dysfunction, but only some people with hypogonadism do have erectile dysfunction, but not all actually.
Thank you, sir. Dr. Dinesh.
so there's one question regarding the nutritional advice that you give to these patients, Dr. Silver, the nutritional advice that you are giving to these patients of erectile dysfunction.
Generally, I think, thank you very much for the question. Generally, I think the nutritional advice should be in keeping with what's given to all patients with diabetes, to keep their diabetes within control. You will find a lot of people popularizing some diabetes, some foods, particularly seeds, pumpkin seeds, and everywhere, particularly in East Africa, for example, that pumpkin seeds do increase libido and other foods do increase libido. But generally speaking, I think it is to keep the blood glucose within normal limits. Regarding this study, it would have been quite interesting if we had sufficient numbers to divide the groups into two categories, those who are poorly controlled and those who have very good control. You definitely would find that patients with an extremely poor control, A1C above 10, and those below 10 would have differences in their sexual dysfunction. And as we see, there is an interaction between age and poor glycemic control. The older you grow with diabetes, the more difficult it gets poorly control, the more difficult it is to control. So diet here is mainly to improve the glycemic control right from the start. As we say in East Africa, hit early, hit hard. So if you do that, like you kill a snake, if you do that early, then with your diet, it probably will continue being good to the end.
Thank you, Dr. Silver. Dr. Sanjay, there is one question we like to get your advice on that. Should we, as a group, should we have taken fasting insulin samples from the patient? Should fasting insulin sample be included in our study, or let us in any future study?
Not required actually, because even Dr. Sushil and Dr. Silver both will agree with me. We very, very rarely ever have to prescribe an insulin assay, or we have to test insulin in endocrine practice. It would not have made any difference. Finally, what counts is the glucose level, which can be measured by HbA1c or by glucose. If at all something had to be done, we could have done an ambulatory glucose monitoring. We could have done time in range. These are things that could have been added. Regarding nutritional advice, erectile dysfunction is one place where we must really India is. We tell them, see, you're not keeping well. One particular organ of your body is not keeping well. The reason is that blood is not able to reach that organ. So why is that so? That is because the arteries have been blocked either by high levels of sugar, or by high levels of ghee or cholesterol, or by tobacco. So if you take away the tobacco and the ghee or cholesterol and the sugar, then these vessels will come back to normal. So that's a way of motivating them to stop tobacco. In India, we use a lot of functional foods. And so one of the libido increasing foods that we use is cinnamon. And very, very good quality cinnamon comes from Sri Lanka, from Kerala state, and also from Tanzania, from Zanzibar. We also suggest cloves to our patients. And in Lucknow also, many people will be aware, the pan, because pan is something that is endemic to Uttar Pradesh and also to the surrounding states. So the pan wala guy, he will sell something called a palang tod pan. Palang means bed, tod means break, and so a bed breaking pan is something that is sold to increase libido to the youngsters. That actually contains a lot of dalchini or cinnamon. So that's a functional food that can be used. We also, like Dr. Silver said, we reinforce the fact that you should have a healthy diet with more of colored vegetables, colored salads, colored fruits, and that helps them. Serum insulin, again, Dr. Sushil sir, would there be any indication at all to check serum insulin in a patient with diabetes? And even if you were to do that, why would we not check a C-peptide?
Muted. He's Dr. Sushil, sir. You have to unmute yourself.
Sorry, yeah, sorry. I fully agree with Dr. Sanjay and Dr. Silver that we hardly require any insulin levels to be measured type 2 diabetes or type 1 diabetes. We can measure C-peptide with type 1 diabetes, but that's only in the studies. We are doing some research studies otherwise, because HOMA-IR and all those parameters of insulin resistance sensitivity, they require it, but clinical practice, we hardly require it. We hardly require it.
So there is one more. I would like to have your opinion, Professor Sushil. What is your opinion regarding once daily PDE5 inhibitors given to these patients? What is your experience,
Sorry,
Dr. Sushil?
sorry. Can you repeat the question?
Once daily PDE5 inhibitor given to these patients. Once daily dose of PDE5 given to these patients.
Which drug? Actually, you have got multiple drugs in that group of medication.
Any drug, tadalafil.
See, sildenafil has got action of 4 to 6 hours. Sildenafil has got action of almost 36 hours. So it is normally advised that sildenafil can be given on alternate day. That's the reason it is known as weekend pill actually. So you can use sildenafil once in a day, but you hardly require it. Actually, it can be done alternate days. That's all.
Thank you, sir. Thank you. So, now it's time to move on for the next topic. Thank you, chairpersons, for your expert opinion regarding our study. Next in the line, we have Dr. Arun Pandey. He will be talking about erectile dysfunction, pathophysiology, and its management. Dr. Arun Pandey, he's a MD/DM endocrinology consultant endocrinology department of endocrinology, diabetes and metabolism, Sahara Hospital. He's the director, Lucknow Endocrine Diabetes and Thyroid Clinic, Lucknow, Uttar Pradesh. He's an executive member of our own society, Lucknow Diabetes Study Society. He's a Padmakar Tripathi Young Scientist Award of UPDA 2019. 30 publications, both national and international. His areas of interest are endocrinology in resource deficient settings, therapeutic and diagnostics. His interest is in monogenic diabetes and electrolyte imbalances. Over to Dr. Arun Pandey for his next talk.
Thank you, Chairperson. I am very glad to present today on an auspicious day wherein we have Guru Purnima and we have esteemed chairperson and my Guru Dr. Sushil Gupta sir in the chairperson panel. Sir was my mentor and guide during my DM days. So I am honored to present in front of sir. So topic of discussion which has given today to me is erectile dysfunction, pathophysiology and management. I'll be going through my talk under following heading: introduction, erectile dysfunction definition, types of ED, pathophysiology, endothelial dysfunction management, and a little bit about premature ejaculation. We all know sexual health is an integral part of overall health. It has a major impact on quality of life, so psychosocial and emotional well-being. Sexual dysfunction in men represents a group of common medical condition which is managed by multidisciplinary approach.
Please come on online, full screen, please.
It's full screen. Is the slide visible?
Yeah,
Now.
So
The full screen is not visible, sir. If you can show it in the minimized version. The full screen is cutting the presentation.
okay.
You can just zoom and maximize it if you can.
Is this better?
Yeah.
I'll try a little more. No, this is not right. Is this okay?
This is okay.
Okay. So the erectile dysfunction, the term importance and erectile dysfunction has been used interchangeably. NIH conference advocated the label erectile dysfunction instead of impotence because of obvious psychological issues associated with it. So ED is defined as having difficulty in achieving or maintaining erection, the consistent or recurrent inability of men to attain or maintain penile erection sufficient for sexual performance is called erectile dysfunction. This recurrent inability is to be present for at least 3 months, then we label this as erectile dysfunction. But this rule has an exception in the case of injury or some surgeries wherein this erectile dysfunction can be diagnosed early. Erectile dysfunction is seen in around 5% of individuals who are of 40 years and 95% of individuals who are of around 70 years. It's of two types, psychogenic and organic. Psychogenic ED is caused exclusively by emotional stress or psychiatric disease. It is seen in around 10 to 50% of cases, while organic ED is caused by vascular, neurological, endocrine, or other physical disease, it is seen around 50 to 80% of cases. It is very important to distinguish between psychogenic and organic erectile dysfunction. This will decide the course of treatment. It is also classified as primary or secondary. Primary condition in which man has never been able to attain or sustain erectile erection. This is rare and due to psychological factors like guilt, fear of intimacy, depression, severe anxiety, or clinically obvious anatomic abnormalities. Secondary erectile dysfunction is a condition in which men he could previously attain and sustain erection, but no longer can do the same. Over 80% of such secondary erectile dysfunction have some organic etiology. However, in many men with organic disease, ED leads to secondary psychological difficulties that compound to the problem. So, erectile dysfunction can later on associated with psychological difficulties too. There are many causes of erectile dysfunction, right from CNS causes, vascular diseases, drug-induced, anatomical disorder, hormonal, and peripheral. So we will be mainly focusing on the metabolic part of the erectile dysfunction. Before now we'll discuss the pathophysiology of erection. The brain sends the nerve cells by NANC mediator. This nerve cell in penis at corpora cavernosa start producing nitric oxide. Nitric oxide stimulates an enzyme called as guanylate cyclase in the nearby cells. The guanylate cyclase convert GTP to cyclic GMP. Cyclic GMP may causes relaxation of the arteries. This relaxation increases the blood flow. PD phosphodiesterase is a decomposes this cyclic GMP to GTP. Cyclic GMP is produced as long as the brain is sending the message to the peripheral tissue. As soon as this signal stops, this cyclic GMP is deactivated and it is completely reduced by phosphodiesterase inhibitor. So we have seen this thing, NANC, it stimulates to release nitric oxide, then cyclic GMP is formed. This cyclic GMP leads to reduction in concentration of calcium, smooth muscle relaxation, increase in flow of blood into the penis, which leads to erection. So this is a transverse section of the penis in the flaccid state and in the erect state. In the flaccid state, the vessels are, as these are the vessels which we see. In the erect state, the vessels are dilated and we can see the sinusoid engorge with filling of the vessel and erection happens. There are many risk factors for same: diabetes, hypertension, stress, anxiety, depression, unhealthy diet, physical inactivity, obesity, smoking, and alcohol. These are all well-known risk factors for erectile dysfunction. 2 slides about erectile dysfunction with diabetes. It is seen in around 35 to 75% of individuals with diabetes. Around 75% of men will suffer from some form of erectile problems during their lifetime. Men who have diabetes have erectile dysfunction earlier than that of those individuals who don't have diabetes. Around this precedes in individuals with diabetes by around 10 to 15 years. How does erectile dysfunction happens in individuals with type 2 diabetes? Type 2 diabetes, it is well known that there is a low testosterone associated with type 2 diabetes, which leads to reduced endothelial nitric oxide synthesis, which lead to endothelial dysfunction and erectile dysfunction. While type 2 diabetes is an inflammatory state, leads to increase in the inflammatory markers, which leads to histological damage, erectile dysfunction. Also, due to inflammation, there is increase in asymmetric dimethyl arginine which leads to endothelial dysfunction and erectile dysfunction. So, what are the mechanisms of erectile dysfunction? Root cause of erectile dysfunction is endothelial dysfunction. May it be hypertension or diabetes. Hypertension by increase in the pressure in the lumen, damage to the lumen of the artery leads to endothelial dysfunction. While diabetes, there is increase in the free glucose flow in the blood, reduces the production of nitric oxide, and there is endothelial dysfunction. Endothelial dysfunction is the starting point of cardiac and metabolic complication. Endothelial dysfunction begins in which artery? Obviously, those arteries which are the smallest. So penile artery is around 1 to 2 mm, coronary artery 3 to 4 mm, carotid artery 5 to 7 mm, femoral artery 6 to 8. This leads to involvement of these arteries lead to erectile dysfunction, ischemic heart disease, stroke, or claudication respectively. Because of the smaller size and greater surface area, the same level of plaque burden and endothelial dysfunction has a greater effect on blood flow through penile artery than through coronary, carotid, or femoral artery. Therefore, clinical manifestation of penile endothelial dysfunction may become evident before the consequence of coronary or peripheral vascular disease. By the time large vessels are 50% occluded, there is a lot of decrease in the blood flow through the penile artery. Erectile dysfunction is the more frequent in individuals who have diabetes along with CAD. Like there was a study done in those individuals who had asymptomatic CAD with those who do not have CAD. It was seen in 33% of individuals who had asymptomatic CAD had erectile dysfunction, as against only 4% of individuals had erectile dysfunction without CAD. It is known that ED precedes CAD by around 5 years, and it is a strong predictor of silent CAD. So erectile dysfunction is equal to endothelial dysfunction. Treating erectile dysfunction at right time can help in preventing CAD at nascent stage. So this was about the definition, risk factors, pathophysiology of erectile dysfunction, and endothelial dysfunction. Now we'll go to the management of erectile dysfunction. Before going to the management, a word about questionnaire. Questionnaires are very important. Like in my clinic, what I do is give questionnaires to the patient who are waiting in the waiting area. These questionnaires are not the questionnaire which Dr. Vivek said, the IEF. It's a general questionnaire which has questions like, since how long you have diabetes, do you have pain in the chest while walking. One of the questions there is, do you have problem in sexual life? So writing this question in that questionnaire helps me. Many times patient can't come and speak out that they have this problem, but when they tick it there or leave it blank, that is a time wherein I'll know now I have to discuss this thing with patient. There is obviously something there. So this breaks the ice, and at least we come to know there is some problem with the erectile function of the patient, and better to discuss this. So questionnaires are very important. We should use validated questionnaire. Those are beneficial. These tools can be self-administered, and it and provides much information in efficient, non-threatening manner. Sometimes it becomes difficult to ask some question. If suppose we write it down, patient can just take the question, the options, and that makes our life easier. There are validated instruments designed to evaluate sexual and erectile function. They have very good use in establishing the response to therapy and determining the overall satisfaction. And it is also very important to differentiate between psychogenic and organic dysfunction. How to differentiate between psychogenic and organic erectile dysfunction? Usually, the spontaneous nocturnal and early morning erections are present in case of psychogenic erectile dysfunction. It gets lost in case of organic erectile dysfunction. ED can be this individual can have depressive illness, performance anxiety, couple dysfunction. This will give us an idea that this erectile dysfunction is probably psychogenic. Also, there is a method like nocturnal penile tumeness and rigidity test using RigiScan, which can be used. But this is of less important in clinical practice. Rarely do we require it. Most it is only of use in not of much use in clinical practice. It is of greatest utility in medical legal cases and investigating pharmacological studies to assess the treatment impact. So, if suppose we are planning to treat, now we have established that in this individual has organic erectile dysfunction, the first and most important thing will be lifestyle changes, improving eating habits, reducing the fat content, having diet which is appropriate for diabetes, quit smoking, alcohol, regular exercise, and medication. This is a time wherein, if suppose we emphasize the importance of quitting tobacco and alcohol, the compliance is very good. Patients are more prone to follow this advices. Otherwise, it is many times difficult when we ask a patient to quit tobacco, quit alcohol. They many times don't do that. But if suppose we say at this time, many times they follow this thing. Important, and one more important thing is, if suppose there is some any drug history of intake of these drugs which has been shown, like antihypertensive, antidepressant, antipsychotics, which leads to erectile dysfunction, this should be discontinued and seen how the patient respond. If suppose there is no response, then probably they will require treatment. Many of them, they can respond just by stopping these drugs. So what are the investigation which we should do if suppose we see organic dysfunction? We need to do a complete blood count, a evaluation for diabetes, lipid profile, kidney function, and liver function. Rarely we see in our clinical practice that individuals can come with organ dysfunction and the presenting complaint would be erectile dysfunction, and when we evaluate, we see this abnormalities. So this is the usual investigation which is required in those individuals who have organic erectile dysfunction. When to do endocrine evaluation? This is an important thing. This is a dilemma which is always there in a clinical practice. Men with ED who have hypoactive sexual desires, they should go for hormonal evaluation. Those who have delayed ejaculation, they go for hormonal evaluation. There is reduction in the ejaculate volume, then they should go for the hormonal evaluation. Failure to therapy to PD5 inhibitors, that is also an indication that this individual should go for hormonal evaluation. Canadian Diabetes Association says those individuals who have diabetes and ED should go for hormonal evaluation. A word of caution for this line is that testosterone is the test which is usually recommended. It should be done early morning because testosterone has a rhythm. It is highest in the morning time and its low level lowers by the evening. So if suppose by mistake we do the testosterone in the evening or the afternoon, that might come as falsely low and unnecessary, we might treat the patient. Also, testosterone, when it is more than 11, it is considered as normal, 11 nanomole per liter. Between 8 to 11 is the gray zone. Between 8, below 8, it is considered to be low. So it is very important not to treat marginally lower testosterone like between 8 to 11. And also, it should be documented at least 2 times, then only we should treat it. One more important thing, rarely we can treat individuals with testosterone between 8 to 11. If suppose we give testosterone, there is symptomatic benefit, then only we should continue the treatment. Otherwise, we should discontinue it. So what hormonal evaluation is required? Usually, testosterone is the only first line assessment which is required. But sometimes wherein individual, they come and there is difficulty in follow-up. This patient might not come for regular follow-up. To reduce the time lag between first symptom and complete diagnosis, we can advise following investigation in the form of TSH, prolactin, LH, FSH. which might be performed along with the testosterone. So this was about the evaluation part of erectile dysfunction. Now we'll go to the management. Medical management is the management which is now commonly done. PD5 inhibitor discovery has revolutionized the treatment of erectile dysfunction, and it has significantly reduced the lag between the symptom and start of treatment. There were not very much treatment available before the 90s. Now we have good treatment. There are many PD5 inhibitors available, which we can see on the screen. These are their pharmacological characteristic. I'll be discussing about this three: sildenafil, tadalafil, and vardenafil. These are the three widely available PD5 inhibitors, and it is approved almost world over. Sildenafil, it has a Tmax of 60 minutes between 30 to 120 and T half of 4 hours. One important thing is that it should be avoided with fatty meals. Fatty meals delay the Tmax of sildenafil. It is available in the dose from 25 to 100. Maximum dose is 100. Efficacy is, all the PD5 inhibitor have similar efficacy. Dose adjustment is required in individuals who are more than 65, hepatic impairment, renal impairment, concomitant intake of drugs, cytochrome P450 3A4 inhibitor, especially ritonavir and erythromycin, concomitant use of cimetidine. Contraindications are, this is an important thing which we should be careful. Any person using nitrates either regularly or intermittently, they should not use PD5 inhibitor because they might be dangerous hypotension associated with it and known hypersensitivity to any component. Tadalafil, it has a Tmax of 120 and T half of 17.5 hours. The absorption is not affected by food. It is available in dose 2.5 and 5 milligram daily, 5 milligram and 10 milligram, 20 milligram as per demand. Rest all characteristics are similar to that of sildenafil. Vardenafil has almost all the characteristics similar to sildenafil, a median Tmax of 60 minutes, T half of 4 hours. Fatty meal causes reduction in absorption of vardenafil. The dosage are 2.5, 5, 10, and 20 on demand. The side effects associated with PD5 inhibitor are headache, flushing, dyspepsia, nasal congestion. Rhinitis and sinusitis are especially associated with vardenafil. So there is no significant difference between efficacy, safety, and tolerability of all the PD5 inhibitor, but they should not be used with nitrate. This should be very important. If at all individuals, if they develop MI or any event, they should inform their doctor that they had taken PD5 inhibitor, so that doctor has to wait for the washout of PD5 inhibitor, then only nitrate or the nitroglycerin, which is used in treatment of MI, then only it should be used. Otherwise it should not be used. So it is very important to educate a patient. If suppose they develop some event, they should inform the doctor about the use of this drug. So tadalafil and the sildenafil are the two agents which are commonly used. A comparison between the two: tadalafil has a longer half-life, sildenafil has a shorter half-life. Because tadalafil can be used once a day, so it may not require to plan the sexual activity. While using sildenafil, sexual activity should be planned.
Dr. Arun, you have 2 minutes to conclude so that we can take up a lot of questions which are coming up.
Okay, sir. Tadalafil is preferred in the young individuals. Sildenafil is preferred in the older individuals. So this is the usual flow of event. One important thing which I want to emphasize is that once we have diagnosed organic ED, a trial of PD5 inhibitor should be given. And if the individual has taken 4 to 6 doses of PD5 inhibitor and still he doesn't have any response, what is the time when PD5 inhibitor failure should be considered. So it is very important 4 to 5 doses of PD5 inhibitor once when it has been taken on a single on different 4 to 6 different days, and still if there has been no response, that is the time then we'll say that PD5 inhibitor response is not there. Many times those individuals who don't respond to this on-demand PD5 inhibitor dose, they might get benefit of daily doses of 2.5 or 5 mg of tadalafil in the evening, and this sometimes require a long time, around 3 to 6 months for response. So it is very important, if PD5 inhibitor if used, it should be given for at least 4 to 6 doses. After that, after the failure of this on-demand PD5 inhibitor, daily tadalafil can be used. And many individuals who don't respond to on-demand tadalafil, they respond to daily doses of tadalafil. And if suppose they don't respond to this, then vacuum devices and other agents can be used. Premature ejaculation coexists with around 1/3 of patients complaining with ED. The definition is persistent or recurrent ejaculation with minimal sexual stimulation before or shortly after penetration and before the person wishes it. It is of lifelong or acquired. Lifelong is usually it was present from the first sexual encounter and it was present always. Ejaculation has 3 phases: emission phase, bladder neck contraction, expulsion phase. How this is an important thing. Ejaculation is controlled by a serotonergic pathway, and how does it is managed? It is managed. It is the management of premature ejaculation is done by detailed medical and sexual history, physical examination, identify obvious causes and genital immunity. One important thing of acquired premature ejaculation is we should rule out infections, especially local infection or unilateral. Sometimes they may cause acquired premature ejaculation. The drug used for treatment of premature ejaculation is dapazoetine. The dose is usually 30 to 60 milligram. It is the first approved SSRIs. It is safe and effective. A word of caution with dapazoetine, as it may be associated with postural hypotension, and many times individuals with diabetes may have postural hypotension due to autonomic dysfunction. We should first rule out postural hypotension before giving dapazoetine on demand. The mechanism of action is it is an SSRIs and it inhibits the serotonin uptake. Last 2 slides. There are premature ejaculation are of lifelong, wherein usually medication is required. Rarely they require counseling. Acquired premature ejaculation, many times they require medication along with psychotherapy. Normal variation, wherein there is ejaculation between 3 to 8 minutes, they require psychoeducation and reassurance. And premature ejaculation like dysfunction, wherein they have ejaculation between 3 to 30 minutes, they usually require psychoeducation and psychotherapy. They don't require any treatment medically. So to conclude, erectile dysfunction is associated with endothelial dysfunction. Questionnaire help in evaluation and management of erectile dysfunction. Erectile dysfunction is managed by on-demand PD5 inhibitor or daily PD5 inhibitor. It is associated with premature ejaculation in 1/3 of cases. Premature ejaculation is managed by on-demand dapazoetine. When premature ejaculation is associated with ED, it is treated with PD5 inhibitor or combination of PD5 inhibitor with dapazoetine. Thank you. Over to the moderators.
Thank you, Dr. Arun, for such a wonderful talk. There are a few questions coming up in the chat box. Thank you, Dr. Arun, for this wonderful talk. There are a few questions coming in the chat box. There's a question for discussion. What is the difference we find in the use of PDE5 inhibitors in a diabetic patient and a patient who is a normal, non-diabetic? What is the difference between the response to PDE5 inhibitors? Dr. Silver?
I think, sorry. Thank you very much. the important thing is that most patients with diabetes do have underlying cardiac disease and may actually be, as he said before, be taking drugs that contain nitrates. So a very good history needs to be taken. Remember, some of these patients may not know all the drugs they are taking, and therefore caution has to be taken when being given these tablets. I have one other addition that I need, which was not highlighted in the very excellent talk is given, and that is the testosterone and weight gain and obesity. We do know that patients with obesity do have levels of low levels of testosterone, and weight loss actually does correct this. So that is a very important thing to look at. Patients who are type 2 diabetes in particular do tend to be obese, and weight loss does improve their sexual function. The second thing is exercise. Physical exercise is very good at improving sexual function. However, caution should be taken that it's moderate exercise that is good for improving sexual function. Strenuous, endurance exercise may actually result in loss of libido. And therefore, that has to be taken into consideration. I think that's enough for the moment.
Thank you, Dr. Silva. Dr. Sanjay, your opinion regarding the use of PDE5 inhibitors, the response in the non-diabetic and diabetic patients?
Yeah, because of all the reasons which Dr. Silver has mentioned, the response is sometimes suboptimal in people with diabetes, especially in those with uncontrolled diabetes. So the trick is to increase the dose of sildenafil or tadalafil. You can also interchange. Suppose one drug is not acting, you can always try the other one. Also see the timing of administration. It is possible that the time gap between the administration of tadalafil or sildenafil and the sexual act is too little. So you can increase the time gap. You can always try tell the patient. So this is called expectation setting. Suppose you tell the patient that this drug will act from dose 1, and let's say for whatever reason it doesn't act on night 1, the patient is going to lose trust in you. But supposing you tell the patient, why don't you take it for a few days? We may have to increase the dose after 4 or 5 days, and within this week the drug will act. My usual conversation with the patient goes as, first your libido will go up. Depends upon what we are giving for the libido. Remember that PD5 inhibitors will not increase libido, but first your libido will go up, then the erectile function will increase, and then you will enjoy the act. So you break them into 3 parts. What will happen when the patient comes back to you after a week? The patient will say, doctor, yeah, I did not have any improvement in erection with these drugs, but my libido did go up. Now, what is the advantage to me as a treating physician? If I had only one endpoint for my treatment, there are 50% chances that I'm putting myself up for failure. The patient will come back next week and will argue with me. And Dr. Silver, believe me, Indian patients can be very argumentative. So, but let us say I have 3 endpoints. The chances of achieving at least one endpoint go up 3-fold. So my chances of failure as a physician come down by 1/3. And when the patient comes back, then we say, okay, yeah, you had this improvement, you didn't have that improvement. Now let's see what we have to do. We might have to change the timing of administration. We might have to change the dose. We might have to change the drug itself. We might have to add daboxetine, right? And it is also possible with the sildenafil, for example, that we might have to give you the drug with a heavy fat meal to increase the absorption. So this is the way we work around this. But all said and done, the response in people with diabetes is slightly less. So you have to use higher doses of these drugs.
Thank you, Dr. Sanjay. Professor Sushil,
Yeah.
am I audible?
We also find that in diabetic patients, tadalafil given on a daily basis and a low dosage probably does better than giving it sporadically in higher doses.
Yes, we have seen that. And so, yeah, so in the practice, one other thing you can do is you can advise it on a daily basis for maybe a week or 10 days until the patient comes back to you. Once the patient is in the mood, in the groove, then you can tell him, okay, why don't you reduce the frequency now, depending upon your requirement. But initially, it's a good idea to give it daily.
Professor Sushil, what is your experience regarding prescribing PDE5 inhibitors to a patient who has undergone CABG? How do you, in your experience, go about prescribing?
It's an absolute. If you are nitrates, then it's contraindicated. Actually, that's one. That's
Thank you,
absolute
sir.
contraindication. That's one. And number two is you have to look at beta blockers. You have to look at his exercise capacity. One has to go for a modified treadmill test on modified Bruce protocol, define exercise capacity actually. Then you advise all these things. That's very very important. If you're nitrates, it's contraindicated.
Thank you, sir. So there's one suggestion regarding a patient getting investigated for triglyceride HDL ratio. What is your take on that? Triglyceride HDL ratio. What is the significance and how it is helpful in the management of insulin resistance, let us say, which is the root cause of all these problems?
You are saying LDL HDL ratio, right?
Triglyceride HDL ratio.
You are saying triglycerides HDL ratio. Is that right?
Yeah. Yes. Triglyceride HDL ratio.
See,
Somebody has suggested.
high triglycerides. It's not a great marker actually. If you want to, it's not a great marker. You have a diabetic dyslipidemia characterized by high triglycerides, low HDL and little on higher side of LDL. That's a typical diabetic dyslipidemia. It does not add much to the value of defining resistance. If you're obese and have a conscious nigricans, then you have a insulin resistance. These are the small sideways of assessing it, not in the mainstream. Yes, not in the
Thank you,
mainstream.
sir. Dr. Sanjay, one interesting question from you. For you, you
I have
actually
to
deal
leave for a
with.
meeting. Actually, can I disconnect now? I have to leave for a meeting. Can I disconnect now? Yeah.
Yes, sir.
Thank you.
Thank
Thank you very much for involving me. And thanks, Arun. Thanks, Sanjay. Thanks, Dr. Silver. And the nation
Thank you, sir.
Muklesh. Thanks a lot. Thank you.
you.
Thank you very much.
Thank you.
So, very practical question for you, Dr. Sanjay. In fact, you deal these patients very well. We have been listening to you for such a long time. There's one question: how do you deal with the case impending divorce because of ED? How do you
Very,
deal with that?
very tough.
You are the
Uh,
best person to deal with it.
a few general rules. Number one, the success rate is not going to be good. So do not spend too much time and energy on this. If you're a busy practitioner, you may wish to use your energy elsewhere. So after having said that, we should still try our best. Number one, get the couple to you together. If the couple is not willing to come to you as a couple, chances of success are even less. Number three, try to find the etiology. If it is all pervasive or global erectile dysfunction, that means that the male, the patient, is unable to have intercourse with his wife or with any other partner, and is also not able to masturbate properly, then again the chances are minimal. But supposing it's a psychosocial issue, the patient says, alone I'm fine, I can handle life alone, I can do solo yoga alone, or I am okay with other partners, then you try to probe further. Some of the common causes that we will find include a different gender orientation, or like for a different gender. That's a very commonly seen thing. Then what you try to do is you just try to get the boy out of this relationship in a very soft manner, in a diplomatic manner. Otherwise, if you're able to find an etiology and correct it, then you bring the couple together, explain to them. If the couple does come to you, then the chances of success are good. So you have to follow what we call Masters and Johnson's technique. Again, non-threatening to threatening. First, you get them to become friends with each other all over again. You tell them to sort of take out all the family members and all the society members, everybody who's poking their head and nose into this personal affair. You tell them to get rid of them. Let them stay alone, become friends. First, at least let them learn how to hold hands. That's a beginning. You can get that done in the OPD. Okay, now you're able to hold hands. Now, why don't you move your hand? Why don't you explore each other's anatomy? Again, in a very non-threatening manner. You do it at night. And you give them homework for every week. So in the first week, the homework might be, why don't you touch each other's body, every part of each other's body, in every way possible? This itself is a homework for a full lifetime. But this is the only homework you are giving them for the first 1 week. Touch each other, explore each other. Then you move on to non-penetrative sex. Why don't you hug? Why don't you kiss? And then you move on to penetration. So you go stepwise. You get them to come to you every week, and within a month, usually things are fine. But the prerequisites are: number one, the couple has to come to you as a couple, and number two, you have to have the time and energy to deal with that. So in an Indian OPD, this is quite difficult to do. We do it sometimes. And like I said, but right at the very beginning, you can make out whether you are going to achieve success or not.
Thank you, sir. So one last question. This is actually we theoretically we read about daily dose of PDE5 inhibitors for long duration. Dr. Silver, Dr. Sanjay, I would like to know your opinion. What is your experience? What side effects do the patients come up with when we are giving PDE5 inhibitors on a daily basis? What complaints, what side effects patients come up with? That is the question. What is your opinion when these patients come to you?
Thank you very much. Generally, the dosage we use is very small, 5 milligrams of tadalafil on a daily basis. Generally, does not have much side effect. You don't actually get much side effect with it. And yet, actually, the response is very good. The commonest side effects you get with higher doses is the headache, the blueness people get, and of course, sometimes the other associated side effects. But at the dosage, the low dosage of 5 milligrams, we rarely get any side effects. That's at least from our experience.
Thank you, sir.
Agreed with sir. Exactly the same. Exactly the same.
So now we are coming to the end of this CME. We had excellent talk from all the speakers and great words of wisdom from all the chairpersons. Now I would like to request Dr. Nitin Ranjan to say a few words regarding our overall CME and formal vote of thanks to the chairpersons and speakers.
Dr. Nitin, unmute yourself. Dr. Nitin?
Dr. Nitin, unmute yourself first of all.
Yeah, thank you, Dr. Dinesh. And I think it was one of the best CMEs that I have gone through. It was just wonderful. And let me start my thanks from a quote from Ramayana, which is that to become enlightened, we need the company of enlightened persons. And to get the company of enlightened persons, we need God's grace. So it was really God's grace that we got the company of such enlightened persons and we had such a mind-boggling and enlightening session. So for that, first of all, from core of my heart and from all my society, I would like to thank Dr. Silver, who has spared his busy schedule and time, who has come with us and enlightened with his knowledge. I would really like to thank Dr. Sanjay, who has been probably one of the most cheerful endocrinologists India has got. I really thank him for his smiling face, for his admiring thing. Really thankful. Dr. Sushil has left. He is also one of the most brilliant endocrinologists of Lucknow. He has been helping us all for us. I would like to thank all the speakers. They were all wonderful speakers. Dr. Vivek, Dr. Arun, Dr. KP Chandra. And finally, I would like to congratulate as well as thank our president, Dr. Rajiv Awasthi, who has been the man behind all this mission. He has been always encouraging to us and he has been the main motto behind all these things.
Thank you.
I am sincerely thankful also to the Corona Remedies for their unrestricted grant for the organization of this program. And last but not the least, I'm also thankful to all the audience who have made this program successful. I would pray to God that such successful programs always come in future. Thank you.
Thank you, everyone.
Thank you.